So I'm here to deliver some of our results from an earlier study that we've done. So this is the bioabsorbable stent study. It's what we call the DISAPEAR study. These are the disclosures. So it's plain balloon angioplasty still effective. We've seen this slide in the presentation previously about restenosis and recoil after balloon angioplasty, leading to high restenotic rates and high reintervention rates. So currently, the needs and solutions are below knee. We need reliable lumen gain. We need to inhibit restenosis to prevent lower TLRs and heal those wounds a little faster. And we are faced with small vessels, calcium, poor outflow, long lesions, and inconsistent drug delivery with drug-coated balloons. And all this with a plethora of things like balloon angioplasty, atherectomy, drug-coated balloons, and drug-eluting stents. But we do see some positive DCB data with the endpoint of efficacy endpoint of freedom from occlusion and major limb amputation. And this was a negative DCB trial just presented in the EuroPCR by another Singapore group with the BioLux balloon, where they actually showed angiographic follow-up, good angiographic follow-up actually, with similar primary patency between the two, as well as no difference in limb salvage and amputation-free survival. So the problem with drug-coated balloons, we can't guarantee consistent luminal gain with POBA, and how do we think that drug will make an effect? Of course, drug-eluting stents, coronary drug-eluting stents, been around for a while. It offers a scaffold, reliable lumen gain, drug delivery, prolonged drug delivery in certain cases, and an absence of distal embolization. Cons is the problem of a metallic implant, and of course, certainly cost. Now, the Abbott bioabsorbable stent has been available for a while, but has been withdrawn from the coronary space primarily because of problems of stent thrombosis. We sought to investigate this. So this is the first report from Ramon Varco. In our institution, we sought to investigate this with a registry. It's called the DISAPEAR Registry. This inclusion criteria was infraepithelial lesions 4, 5, and 6 Rutherford, stenosis more than 50%. Exclusion was anything around the ankle joint and restenotic lesions. So these are our patients, 90% diabetic rate, 12% renal failure, 80 or over 90% Rutherford 5 and 6. Mean lesion length range was 22.7, ranging from 4 to 88 millimeters in length. So some of these lesions were actually quite long. I'm very happy to share with you our early results with the 6-month results. Primary patency with a PSVR of less than 2 was at 6 months was 95%. Freedom from TLR was 98%. Freedom from target lesion revascularization on ultrasound occlusion, similar to the Lutonix endpoint, was at 6 months was 98%. Amputation-free survival was 93%. Median time to wound healing in our group of patients was about 4 months, and 86.8% of our Rutherford 5 and 6 actually healed at 12 months with wound care. Some case examples: a pretty young lady with a pretty disastrous hole in the leg. She was treated with a bioabsorbable stent in the anterior tibial artery. Another patient with Rutherford 6 gangrene was treated with a bioabsorbable stent in the peroneal artery, was stacked up like that. And getting a good angiographic result like that. And 1-year imaging follow-up, all the other tibial vessels had occluded, but the peroneal artery remained biphasic, and on MRA showed a good flow as well. Another patient with Rutherford 6 gangrene, popliteal lesion, and anterior tibial artery was, of course, this was funded by the government, and this is treated with stacks of bioabsorbable stents with a short superior stent in the popliteal artery. This patient remains 3.5 years. All stented vessels remain patent and no repeat interventions, biphasic dorsalis pedis, and one can appreciate a severe calcification in these vessels. One of our longest 4-year follow-up with a 70 millimeter length lesion. This patient with an anterior tibial artery that was treated originally in 2012. 3 bioabsorbable stents were stacked up. On control angiogram in 2016, this remained patent. And you can see the markers of the bioabsorbable stent. But what was more interesting was that if you compare the anterior tibial artery prior to bioabsorbable stent implantation, and 4 years after that, you can see disease progression in the anterior tibial artery, but you see no disease progression in the portion of the artery that had been stented, and maybe the bioabsorbable stent allowed the vessel healing to occur. And this patient actually developed a neuropathic ulcer, but did not require further angioplasty, and with the patency of the stent, we were able to heal this wound without re-intervention. So in summary, BTK lesions are associated with recoil, high restenotic rate, and a high reintervention rate as treated with standard POBA. There may be a role for scaffold and drug elution to give reliable lumen gain and consistent drug delivery. Our experience in our registry is encouraging with good patency rates, low TLR, high limb salvage rates, and we eagerly await the next generation BVS dedicated for BTK interventions. Thank you.